welcome to another episode of Let's Talk About Mental Health. I'm Nels Kloster. I'm an addiction psychiatrist. I'm working in Southern Vermont.
And my name is Robert Stack, and I'm a licensed alcohol and drug counselor.
Hey. We've been appreciating people's questions, and as a reminder, we have a Facebook site at facebook.com/letstalkvt. And for emailing questions, questions at letstalkvermont.com.
Okay, and I want to jump back to 2 weeks ago. Last week we were with Susie Walker talking about turning points, but 2 weeks ago, and that would be episode 12, season 3 for people who want to keep track of this. But we had some really good questions come in, and the last one what we did, we felt sort of rushed. So I want to just go back to it just for
let's take, because we sort of promised we would do that.
We did. And so this is a person who talked about being in an alternative community and how sometimes some people talked about having abstract thinking and mystical visions, things that sort of changed their lives, but many of them viewed it as a spiritual experience. And so the question became, at one point here, when do you think a person should seek medical help when having these type of experiences? If a person considers these experiences to be authentic, should they turn to spiritual guidance and the doctrines of the spirit of the world's religions, or should they consult a psychiatrist?
Right, and then part of our answers in response to that was the idea of, when does a belief become mainstream? How many people have to believe a similar thing, like say, Christianity or Islam or Mormonism, versus say cults like Jones, the Jonesville cult with the drinking Kool-Aid. And how really there's a broad variety of sort of reasonable beliefs, and oftentimes these sort of beliefs can be very sort of fixed and firm, and they don't necessarily mean that somebody's ill. They don't impact somebody's functioning. And then I think we went on to talk about along spiritual domain, that the idea of sort of Bill Wilson's experience, which could have been described as sort of ecstatic sort of awakening or opening, and also how many people sort of seek that and think that that is the notion of a spiritual awakening. And we mentioned how actually kind of relatively rare that is, but how many people will sort of go to hallucinogenics like LSD to try to have that experience. And really that's maybe a cheat or a shortcut, but that what's really required for spiritual development is a rigorous practice, to be working hard at something to have spiritual growth.
And I think in some ways, and I mentioned this last week or 2 weeks ago, there's a certain process of seeking it, looking for it, trying to get to a deeper understanding. And I remember like in the 60s or 70s, what was it, he drank the peyote, Castellani?
Oh yeah, Carlos Castanedas, right?
Yeah, and I remember a lot of people reading that. And again, it was people, and I understand, at least I believe I understand, that there's more to life than just what you can think about intellectually, and there's more to life than just your physical experience of life. That there is a deeper meaning somehow, at least, and looking for that, trying to make rhyme or reason to that. And sometimes you experience things and you see things. And I just want to say, and again, his question I think is really valid. It's that idea about well, when does this become a psychiatric illness or a psychiatric symptom? And I guess that one of the things, and you mentioned this earlier, does it happen just in isolation? Is there other stuff going on? You can't just talk about this one vision. And I pick up the phone and ask for a psychiatrist, because last night I had a vision. I thought I felt like a presence in my life or something. I mean, it's just, there's more to it than just that.
Right. There's a whole picture around that, and just the fact of hearing something or seeing something doesn't define you as psychotic or crazy. And one of the things that we realize is that there's that expression, right? We're not human beings having a spiritual experience. We're spiritual beings having a human experience. And there's such a broad range. And it feels like, I'm always wondering, when did sort of medicine or psychiatry become the ultimate authority on what is sort of normal thoughts and feelings and behaviors.
Right.
Where it almost feels like, especially with sort of pushing medications, big pharma, that we're starting to sort of expand the range of what's abnormal, which then sort of diminishes the range of what is normal. And maybe that's sort of backwards. I think that we read an article in the New York Times by a Stanford anthropologist, T.M. Lorman, who talks just about this sort of thing, that is not necessarily abnormal to hear voices.
Right, and this is a good time to sort of mention this. This was an article written in the Times, and it was, I knew her father when I worked at the hospital, Dr. George Lorman, a good fella, and I contacted her, and she said that she would come on our show, and so we're hoping to have her come on by Skype from Stanford University. And so anybody out there that sort of is acquainted with her writings, she's written two or three different books, and anybody who has interest in that article, I'd like to encourage you to send us questions or comments. I would love to add them to some of the thoughts that we want to share.
We have a link on our Facebook page as well to this New York Times article, which would then send you on to her own website and the books that she's written.
Right.
Yeah. I mean, it's intriguing. She's a what do they call it? A psychological anthropologist. And I remember years ago, the idea of anthropology used to be that you went off and you found these primitive cultures. Anthropology is always looking at sort of other cultures and, examining them and their funky sort of rituals and such, but always sort of kind of looking down on them, I guess, as being sort of primitive and beneath us. More recently, in the last few decades, anthropology has started to sort of turn its lens onto our own ways and our own social norms. And so I'm really intrigued by I'm going to explore her work, because the idea is now we all have cultures. There's a medical culture, people try to deny, but there's this sort of white culture and different professional cultures with engineering and law. And so I think it's really intriguing. They sort of turn the lens back, and she's done that with psychiatry, for example, and really sort of criticized a lot of the things that are considered mainstream psychiatry now, or question them at least.
I think one of her first books was about, she did some field work in India, but I'm not 100% sure, but the second or third book was about the split in psychiatry between talk therapy and medicine and biology, giving people medications, if you will. And in the article in the Times, she says maybe there's a little pushback to talk therapy. Maybe there's a little pushback to that, medication is sort of like, oh, you had the symptom, we're going to medicate it. There's a lot of push to do that. Instead, maybe we should just talk a little bit more and understand more about that. And doing this, and I just want to share a little personal story. I mean, I was a new counselor. I was a young counselor and apprentice counselor. Right? And I was working with Dr. Lorman, and I was full of little information, if you will, And I'd always wanted to. I remember sitting in group therapy with him, and I wanted to talk. Like I wanted to say, like, oh, do this, and I'd actually get impatient with the patients who were talking too much, And anyway, he didn't allow me to talk too much. And after the group therapy, we did it 2 or 3 times a week, and I did it for months with him. But I come to realize that, through him I learned that what he needed to hear was the patients talking. Not me, not him, but to hear them talking. And I really come to understand this as the years went by, that a good counselor is really a good listener. Yeah. I mean, it's really about listening to what people are telling you. And it was very interesting that I learned that from him, only I didn't realize I was learning it. And at the same time, I ran into this slogan where somebody said to me, what you need to do is learn how to listen, and then listen to learn. And that's exactly what I learned from Dr. George Lorman was, that you listen to what people are telling you. Like I thought I had the wisdom, you know what I mean? Like, and all I had to do was like interrupt them and tell them what they needed to do. And it's not that way at all. And then here it is years later, motivational interviewing, and people like that are saying, the answer lies within them. They will find their way to recovery. They will find what they need.
We're just trying to kind of, not to mine it, but leave them the place to be able to bring this out and discover it themselves. I'm thinking of, and I guess it's sort of from a Buddhist ideology, that the beginner's mind is open to all, and the expert's mind is open to nothing. Right?
Well, go ahead. I was the other way. I was the beginner's mind, and I was pretty narrow. I had the answer.
You thought you were the expert, right? Yeah. And I think as such, I think that's really a difficulty with psychiatry right now, and how, diagnoses and the diagnostical statistical manual, the DSM, it's a very top-down sort of thing. We're going to apply this label, and then we're going to dig down and sort of use our interpretations of this and our viewpoints of view and our determined treatments, which are mainly medications. And now what people are talking about is, no, that these sort of lists of symptoms don't necessarily lump together as belonging together and defining an illness. And the British Psychological Society just came out with a 100-page report that talks about just sort of, hearing voices. Understanding Psychosis is called. Mm-hmm. And the idea that hearing voices does not necessarily mean schizophrenia, that there are a number of experiences under which you might consider relatively sort of normal or an expected response to, say, for example, the traumas or deprivation.
Right.
It doesn't mean you're crazy.
And the title of her article in the Times is Redefining Mental Illness. And so here we have with DSM-5 coming out with lots of diagnoses, lots of symptoms, and yet you have other people walking around saying, maybe we don't need to look at everything as a mental illness. Maybe we don't need to focus in on every symptom, every illness, every collection of symptoms and make it a diagnosis and then treat it. Maybe there's another way of sort of approaching this. And anyway, I hope we can follow up on that. And I really look forward to this. And,
that'll be great.
We're going to have to get ready for this.
Let's do some study, And there's different ways of looking at this. And I'm not sure I have the name right, but again, in Great Britain, there's a group that's dedicated to sort of learning how to live with voices. I'm not sure what's listening to voices, living with voices. And it's almost like a 12-step approach, like AA or NA, where you're offering very sort of constructive suggestions or in ways to understand and explore these voices that really does much more for accepting the phenomenon itself, feels more accepting of the people who are experiencing this, rather than turning them off as saying, you've got an illness, now you're sick, whereas it might actually be a very sort of meaningful, almost spiritual experience for them to hear these voices. And so that's a whole different approach. We're looking at this thing that happens rather than attaching to some kind of umbrella meaning.
I can't help thinking of that movie, A Beautiful Mind. I mean, at one point, they show him in the middle of psychosis being crazy in his house and everything. It was really scary for everybody and really freaked them out. There was that moment, and obviously at that moment you would think, we need to medicate this. This is sort of out of control. And yet at the very end of the movie, when he's getting this acknowledgement and award, and they show that moment, they show that the voice is still present. But he's sort of living with it, walking with it, and, almost not, I wouldn't say disregarding it, but not afraid of it. And at that point you realize it's not scary, it's not threatening anymore.
I'm thinking as a married guy, we both have experience with this, is it's called sort of selective hearing. After a while, the other person's voice is still there, but you don't necessarily need to tune into it all the time.
Right. And I want to go into even more about this redefining mental illness, because it's not just schizophrenia, it's not just hearing voices. I mean, we need to take a look at that whole spectrum of bipolar, everything that we get so anxious about, depression, anxiety, whatever way. So I'm really looking forward to this.
Yeah, let's expand the spectrum of what's considered normal.
So we had a question, and this is 2 weeks ago, but I said we would do it, so I'd like to try it, okay? An ongoing debate among my circles of friends is when to use medication to treat symptoms of depression and anxiety versus non-medicated holistic approaches of yoga, meditation, and psychodynamic talk therapies to work through these issues. My question then is, as a psychiatrist, so this is addressed to you, when do you think medication, antidepressants, antipsychotics, stimulants, is necessary and helpful, and when are they harmful? And when does talk therapy help, and what are its limitations? And that's a big
question. I think now, we don't always do this, but the idea that for sort of an algorithm or steps to go through this is that medication should never be the first answer. right? Unless it's really an extreme situation where you're essentially sedating somebody, that there's so many things to do before you would seek a pill or prescription. And for example, we've talked about sort of even like high blood pressure, for example. The first step would be stop smoking, exercise, change your diet, and these sort of behavioral approaches. And I think what we miss out a lot is that there's a quality of life and social connection is probably the best protection that we have, or even the best medicine. So I really like that he listed out these things like yoga and meditation, which actually give us sort of pleasure and a good quality of life. And two, we've seen too with at least what we know is sort of a double-edged sword with the medications. Antidepressants, every medication has side effects and consequences from long-term use. And there's been research that shows, well, one, that we've been misled on the effectiveness of medications because a lot of trials that have shown sort of no results whatsoever from using medications, that those have been sort of kept out of publication. And so it's becoming clear that when you talk about mild levels of depression, that if you are prescribed an antidepressant, you might as well be taking a sugar pill for the impact that it's going to have. And two, we're seeing with antipsychotics, even on schizophrenia, that people who are on these medications chronically don't function as well years out as do people who've been on either low doses or no doses of these medications. So, I mean, for psychiatrists, I personally have a very conservative approach, and in many cases, we're turned off by the idea that give me a pill, it's going to make me feel better.
Right.
But even that being said, a lot of my practice is around with opiate addiction and this medication called Suboxone. And I used to see it a little bit differently, but now as I've matured, I realize it's really just a tool. It has a very powerful effect from staving off withdrawal. And as such, it almost allows me to keep my patients captive in order then to try to start the work of improving their lives, the quality of lives, their relationships, their work, where do they live, how do they start to see that there's a better way of living, and to help them move away from their addiction and move towards recovery, having a full life.
And I hope I'm not taking just the easy way out of this question, but I would say it doesn't have to be an either or. And that another way of thinking about it, and I was a doctor that I have a lot of respect for, Dr. Senior, at one time was talking to me about a case, and he mentioned someone who had been on talk therapy for a long time, but not showing any improvement. Yeah. And he felt like, we'll try the medicine. Let's see. This is important. Let's give medicine. If talk therapy is not helping, if it's not making progress, and you're dealing with somebody, see if there is some medicine that would help. And I think the other way is true too. I mean, if your first reaction to someone telling you they had X symptom or they feel this way is to put them on meds, hold off, like you're saying, like maybe not right away, but I also understand that, a lot of meds are given by people who experience a certain time crunch, almost like, I have to see so many clients, you have so many minutes, you have so much you have to do. And we said about this in another show. Sometimes you have clients come in and they expect medication. Yeah. He mentioned anxiety. And I told you about my experience when someone came in and we wanted to talk about anxiety, and I wanted to introduce him to cognitive behavioral therapy and talk a little bit about that. And he was pretty clear that his significant other, if you will, had access to Klonopin, and he was thinking, gee, maybe I could get some Klonopin. And I was thinking,
works,
yeah, because it did work. I mean, as far as he could tell, and I don't know if he took hers or not, but it was that idea that he was really looking for the easy fix. He didn't want to do therapy. He didn't want to talk about read this book or do this exercise or do some homework. He was hoping for the other solution. So I don't know if there's an easy answer to this, like one is better than the other, but I do think that one should consider both when they're doing this.
Yeah, but I think like there was a study with the divinity students, I think it was at Harvard, and using LSD in the framework of their very rigorous sort of spiritual pursuits versus a group who was not involved with any kind of study taking LSD. And they found that I don't know if it's called medication, but that drug actually, in the case of the hardworking divinity students, actually was sort of a life changer, a mind opener, whereas the folks who were doing no rigorous practice, it did nothing. It was simply an experience that didn't really seem to advance their spiritual life. And as Mary Ellen Copeland, the wellness recovery action plans that we had on the first show of our second season, had said you still have a responsibility to work towards your wellness. And so I think the medication in itself doesn't have nearly the potential, maybe some temporary relief, but you need to be engaged in the talking and the examination and changing your life to really have some impact.
Right. And I don't know about at what point some medications would be harmful. There are side effects, and it depends what med it is, it depends on the dosage, depends how long you are. And so, when you talk about stimulants or antipsychotics or depressants, they're all different meds. And who's taking them and how much you're taking and what you're taking. Like I've worked in a hospital, and I know some doctors would use some meds because their side effects addressed another issue.
Right.
Like there was some other problem, that whether it's sedation or something else, sleep or something. So I think there is a certain science or craft to writing meds. To understanding them and stuff. So again, and what are the limitations of talk therapy? I mean, I don't want to say, because a lot of times I know people have been in therapy for years, and it's hard to pinpoint what's different in their life. And I think one of the things I've noticed is that they feel that someone's listened to them, they're developing a voice, they talk about themselves, they talk about what's going on, and how do you measure what might have happened if they weren't in talk therapy?
Right.
You know what I mean? Like, I'm not real fast to criticize somebody for being in talk therapy for a long period of time. I mean, it could be very beneficial.
Because on one hand you could say maybe it's not effective, therefore you're in it for so much time. Then there's the sort of Carl Rogers talked about sort of positive regard, and to have a professional who really sort of models a relationship that is not sort of harmful or demeaning can have tremendous value.
I remember hearing one time someone who was an adult as a journalist, and people were asking how much benefit was his child psychiatry that he went to, and they were sort of joking about it, that he still turned out the way he turned out and all that, But I couldn't help thinking that one of the things as a writer, and they always tell you, find your voice, and I can't help thinking that while he was in therapy, he developed a voice. He developed, and here was somebody willing to listen to him, somebody of stature, somebody who was, money was involved, and what you were thinking out was important. And I believe in that. I believe with some children, one of the things you have to, when I occasionally would work with young people, is to listen to them and listen to what they're trying to tell you and make them feel important. And I want to know what you think.
Yeah.
It's important what you think. And I'm not there to be critical of it. I mean, like you were saying, the unconditional positive regard is that idea that, okay, I may not completely agree with what you have to say, but I do think it's important. I do want to hear it.
Yeah,
so.
And maybe let's give this person like a concrete answer here.
Okay,
one possibility is you can find any of these on the internet. Beck Depression Inventory, also known as a BDI. Montgomery-Asberg is another one. So these are a couple of scales. You could find them online. You could answer the questions that are questions that give a number value to various facets of depression. You add up the totals, and then you can look at the scale and decide, okay, do I have a mild, moderate, or severe level of depression? And then based on that, an approach that was presented to us in our training was, if you have a mild level of depression, do something pleasant, right? Start to exercise, get together with friends, do something that brings you joy. Watch comedies every night, something along those lines that is just uplifting. If you then determine you have a moderate level of depression, then either talk therapy or medication is a reasonable treatment for that. And in many ways, then go with your preference. If you have more of a faith that medication be useful, you're really sort of doubtful about the idea of sort of talking to a professional where that goes, then do that. If you think that examining what's going on in your life would be more useful, then go with that with the therapy. And if you determine that it's at a severe level of depression, based on these scales, then you should do both of these things. You should be more aggressive, and you should find both a physician and a talk therapist to work on that depression.
And if you don't mind, just my little thing is anxiety. I'm very suspicious because I work in the field of addiction. A lot of people got in trouble with anti-anxiety medications, and I really do believe in talk therapy and cognitive behavioral therapy. And one of the problems that some people take with anxiety medication is I think it gets them into more trouble.
Yeah.
They get over dependent on it. If they have a withdrawal from it, they have even more anxiety.
Yeah. So having said that, really avoid benzodiazepines. They should be a last resort.
Yeah.
That's Xanax, Ativan, Klonopin, and also stimulants. It's very easy to get diagnosed with ADHD, and they can put on like Adderall or methylphenidate, Ritalin, and those should never be the first step you go to. These are medications that really have a worse sort of risk-benefit balance to them.
Right.
So be a savvy consumer and express those concerns to the physician who's prescribing for you, and be careful about that, so we do actually do more help than harm.
Now, I don't know pharmacological that well. I mean, I listened a lot, but one time doctor was talking about anti-anxiety medications, and he said something to the effect that they're very effective short term. The problem is, for some people, anxiety is a long-term. It's a chronic illness, and I think that's one of the places you might get into some trouble with it. I mean, again, everybody's different in the diagnosis and what you're hoping to achieve, but in that question, he sort of lumped them together: antipsychotics and antidepressants and anxiety medications and stimulants. And I think you want to be careful about some of these. I mean, obviously.
Yeah, there's very different properties to each of these different classes of medications.
Right.
Yeah.
So we're up to our last question, and again, this might be a holdover, and this has come up a number of times before. And I imagine it's going to come up again. And this one was someone who wrote in. He says, my doctor keeps pressuring me about my pot use, and I'm telling him that it's going to be legal soon, and leave me alone.
Yeah,
and
back off.
Back off. That's actually so. The idea, and I think it's a legitimate concern. And I want to say something about recently. There was an article. Let me give a little background. Sure. First of all, they decided that they wanted to give it for medical reasons. Right. And they lined up a whole bunch of people that had eye illnesses, glaucoma, children, whatever, and they said marijuana is helpful, it relieves my symptoms, and there were certain people that seemed to benefit from it. And nobody wanted to say, well, no, you can't have it, we want you to suffer.
Because I always brought up like grandmother, and you didn't want her going to the dealer for marijuana.
Or I had a good friend that had glaucoma, and it really did help him see. I mean, so, okay, all right, medically, I don't know what that means, but here, And then I remember, Governor Shunland had all the police chiefs line up and say, decriminalization is a good idea, we don't want to, we have all these potheads in jails, and that's full of baloney, you know what I mean? Very few people went to jail for smoking pot. I mean, unless you blew it in the judge's face. I mean, mere possession, you didn't end up, But anyway, that's what they said. So they decriminalized it. And so right now, there's a study talking about how much money will we get if we have taxes, and how much income it will produce if we sell marijuana. And just recently there was an article in the paper about Rand Corporation, I believe, saying that $100 million if we can become a magnet state and supply all the pot users in New England. I mean, this is just like crazy talk, But no. I mean, Colorado.
We have our bias because
no. If you could just imagine, Colorado has it, and Washington State has it, and if Vermont could have it, we could get stoned and ski. We'll make it a tourist slogan. I mean, it's sort of like, and so we're going to stop people. I'll stop on this, but it's just this idea.
Because it's really complicated. I mean, the short answer might be it's potentially harmful, and physicians don't want to recommend harmful things to people. But the idea of the legal, the jail aspect, the idea that we'll raise a lot of taxes, those are sort of one point. It's a very, very, the Rand report is quite long, and there's much more to it than just those points.
I used to talk to psych patients, and I'd say, it's in your best interest to leave your brain alone.
Yeah.
You really don't need to be getting high.
We should hit this next week.
All right.